colleagues in Delhi kept on taking up this program, and the Indian Council of Medical Research, as well as the UNICEF, as well as the World Health Organization, collaborated to form the first multi-center project to start congenital hypothyroidism screening with other common disorders in Delhi and different other states. The first individual effort to start a congenital hypothyroid screening program was actually initiated in Bombay by Dr. Meena Desai and her colleague Dr. Priska Kolaso. They were the first ones to show that in a non-endemic population, non-iodine endemic population, the incidence of congenital hypothyroidism in general newborn population is somewhere to the tune of 1 in 1,500, much more than what was reported at that time in UK and USA and in several other established national programs. The technology has advanced and it has become at the fingertip of most of the laboratories now. Still, it is costly. It is not within the reach, or sometimes the problems are not only with the technique, but the reachability. Children are not always born in tertiary care centers or in private hospitals. They are born at home. At this moment, almost 33% of the Indian newborns are born not in the primary or the secondary health centers. So reaching out to every newborn is an ambitious venture, but something very difficult to achieve without the participation of the public. Public, I mean, you have to educate the public about the advantages of newborn screening and how the public, through a network of communication, can reach out that everybody, whether they are in Attapadi or in Idukki or whether they are in any part of the state, can get the facility for screening their child within the first 3 to 4 or even 5 days after birth for the screening of congenital hypothyroidism. So it is an ambitious venture, and I congratulate the Kerala IAP team and also the Kerala branch of the Indian Society of Pediatric Endocrinology, again led by the group, to start and head this program into a reality. I have been associated with the development of this program in Kerala when it was started in 2011. And we have seen the growth of this program from the large 4 medical colleges into almost all the medical colleges in Kerala, now into district centers. Now I think you have to reach out to peripheral centers. I am very happy that you are already including the private centers, which are also catering to the needs of this particular screening program. It has been my pleasure to see throughout the length and width of Kerala, starting from, for example, Dr. Rita Gopinath at Pariyaram, Dr. Rajesh in Calicut, Dr. Vijay Kumar at Manjeri, down to Dr. Deepak and Dr. Nitya in Thrissur, in private sectors like Dr. Parvati, and in Alappuzha, Dr. Reshma. Then we have in Malankara Center, Dr. Abraham Paulus, and then down to Trivandrum, Dr. Ria, Dr. Veena, all involved, not only from the primary centers, but also from the government as well as the public-private participation in the establishment of this program has been something which I have never imagined when I joined as an advisor into this program. It has been a realization how to organize it, and I think I should congratulate the entire Kerala team, the entire Kerala IAP team, not only of this year, but of the past years, who has spearheaded this program into a milestone-making program. The establishment of the program at the moment has to concentrate not on the bigger centers, but on how you can reach out to the peripheral centers, that a child born at a primary center or even a rural dispensary, whether it is private or government supported, how to collect a heel prick and then rapidly get it transferred to a regional center nearby. So you have to actually advance the technology of not only just making the heel prick, but establish technology of rapid transmission of the filter papers properly into a tertiary center or a region-based center where tests can be done immediately. It is just not, again, just taking the blood sample, sending it over to the center, whether it is at Calicut, Trivandrum, or Thrissur, but also informing the parents, the mothers who have waited for the babies to be pricked in the first 3 days, and then to know within the rightful period to know whether the child is hypothyroid or not. So communication technology is the breadwinner for this program. Without that, this program cannot succeed. It cannot reach out to the public. You may be doing tests for everybody. So it is important that this program also establishes a communication methodology of reaching out to the mothers within the first 10 days. I would say probably in the beginning, at least within the first 14 days, we should be able to tell the mother, your child has probably hypothyroidism. There is a need for a confirmatory test. There is a need to start a medicine. And then convincing them why it is needed. The proof of the pudding lies in showing to the mothers that their child will grow normally. So if you have to really show that there is improvement in the program, you have not just only do a prick, you not only do a TSH, you confirm it with a T4, but also you have to also see to it that every suspected child with an abnormal test, either screening or confirmed, is followed up meticulously by pediatricians. For what? For growth and development. So it is important that this program should reach out to every pediatrician in the state of properly assessing for growth as well as for development and detect the abnormality at the earliest. It is not enough that you can start on Ectopic therapy or Thyroxine therapy immediately. It is important to assess the adequacy of therapy and correct it appropriately. For that, you need follow-up assessment, not only of growth assessment by a simple techniques which have been designated by Kerala centers have come up with the Trivandrum development scale. We can also evaluate all these. And also, there is a need to follow up these children with follow-up estimations of either TSH or free T4 or total T4, depending upon the availability. It is a continued process. This is not a one-time field prick diagnostic test. It involves continuous assessment, not for 1 month, not for 6 months, not for 1 year, but at least for 3 years. These children have to be followed. Because once you start a child on treatment, the recommendation, international recommendation is that you have to continue treatment for at least 3 years non-stop to ensure that this child will not suffer from a neurocognitive disability. So the proof of success of this program is ensuring a good chain of combination of technologies, which we need, biochemists are needed for the assay, obstetricians to ensure that every pregnancy, right at the beginning, the mothers are encouraged to do newborn screening, making sure that every delivery is either attended by a pediatrician. If that is not possible, every nursing student, every nursing person in the obstetric room or the labor room is geared up to take a sample, cord blood, if there is no facility for taking heel prick later, and training the young medical student about the importance of taking a proper heel prick sample and ensuring it reaches the laboratory. So my congratulations to the Indian Academy of Pediatrics, Kerala, to take up this program in all earnest and start the program and spread it not only into the big centers. Again, my highlight is that those who can come to the medical colleges, those who can come to the district hospitals or to the private centers can even afford these tests. But your aim should be to reach out those people who cannot reach to these centers. So no child is missed for the want of a test. So this is my request to you, to all my colleagues in the Indian Academy of Pediatrics and those who are working. The number of pediatric endocrinologists in any given state is limited. It is not possible that every screened suspected child will be seen by a pediatric endocrinologist. But the pediatric endocrinologist in Kerala should endeavor to see every child at any time of the day and give the advice. And we have to ensure that sufficient knowledge is imparted to general pediatricians about not to disregard an abnormal result, allow screening of babies right as soon as the baby is suspected to hypothyroidism, and that's all. I think I not only congratulate the team, but also see to it that this program has run successfully for the last 11 years in the state of Kerala. Programs have come and gone in several institutions. Even the multi-center studies which are operated by the Indian Council of Medical Research and the Department of Biotechnology were time-bound, ended up after 3 years or 4 years of the beginning. This program should not be a never-ending program. It should continue forever and ever, and we should be able to incorporate recent advances in technology and screening and medication to these children. By this, I mean that, for example, it is not easy for a mother to give 1/4 of a tablet of thyroxine early morning before breast milk into the mouth of a child. We have to make available liquid preparations of thyroxine in the coming years for best management of the newborns. So these things are important. So this program needs continued evaluation and revision. And lastly, I think the newborn screening for hypothyroidism is the beginning for the screening program for all metabolic and rare genetic disorders. For example, the same heel prick sample on a filter paper you can use for congenital adrenal hyperplasia. You can also use it for PKU. You can use it for maple syrup disease. You can also screen galactosemia. There are at the moment, with that finger prick, one drop of heel prick, you can at the moment screen 41 diseases within the first week by simple technology. So every drop of blood that you have collected on a filter paper, a Wartman filter paper, is worth gold for a child born into this country. Congratulations. It's my pleasure to inaugurate this seminar which is being organized to launch this program to the pediatricians and to general public of Kerala by the Indian Academy of Pediatrics in conjunction with the Indian Society of Pediatric and Adolescent Endocrinology. Thank you. All my best wishes for the program. Thank you for the coordinators. My special thanks to Dr. Vijay Kumar, Dr. Riaz, and the nodal officers and the central team who have been actively involved in this program. Thank you.
Thank you, Menon sir, for that enlightening words. Thank you for the guidance and support, and thank you for officially inaugurating the session. Now, may I invite Dr. Shaila Bhattacharya ma'am for the keynote address. Dr. Shaila Bhattacharya ma'am is the professor of Department of Pediatrics, JJMC Davangere, as well as a senior pediatric and adolescent endocrinologist. She is the president of ISPE 2021-22. As Menon sir said, she has also done a pioneer work in the in making 100% screening of congenital hypothyroidism. So, ma'am, we are extremely happy to have you here. Over to you, ma'am, for a few words.
Thank you, Nitya. Good evening, everybody. It's my great pleasure to be with you all, and especially my favorite teacher, even though he said I am his colleague, it is his kind words. I learned endocrinology from him. I started endocrinology, pediatric endocrinology, 30 years ago when he was in AIMS, when I started working under him as a clinical fellow in 1991. So from then onwards, I have been seeing Menon sir. He is the same. He is like the evergreen Devanand of our pediatric endocrinology. Thank you very much, sir. You have been very kind, as always, in helping the pediatric endocrine team. Thank you, Dr. Vijay Kumar, for inviting me. Thank you, Dr. Deepa, for inviting me here. And to talk about congenital hypothyroidism, I think sir has discussed in length. But I think right now, even in Kerala, there are a lot of pediatric endocrinologists. So they would really help every pediatrician or the general practitioners in guiding for diagnosis, follow-up, management of these congenital hypothyroid kids. What I would always say is, if a child is not tested with the thyroid function test, either TSH or free T4, then unless or otherwise proved, the child is hypothyroid. So you have to do a thyroid screening. If you cannot do at birth, at any first interaction with any newborn baby, please do it, because there are many pediatricians here. I request you all, even if they have missed the first time within the 3rd or 4th day, any first interaction, or even if you are seeing the child for first time, go through their papers. If the thyroid screening is not done, please do it, because the test cost is so minimal compared to the consequences of hypothyroidism. Even in metropolitan cities, in all the famous cities of India, many children are missed, and we are detecting them in their childhood, late childhood, even during adolescence. So I think anytime we need to just pick them up and treat them. And once you start treating, please at least once you speak to the pediatric endocrine colleagues and get their advice for their management. This is the only condition where you can prevent mental retardation by early detection during the neonatal period. So I think I should thank the whole of Kerala IAP, Kerala team, Kerala pediatric endocrine team for starting this. And Kerala has always been a role model for any of these science and academic activities. All over India, I think we need to follow the Kerala model. Actually, since I became president, I have been troubling Dr. Vijay Kumar and Dr. Riyaz how to go about it, but still we all have not been successful. I'm still hoping this year we will reach somewhere, but we have started in Karnataka in 3 places as pilot study. So it is the starting of the congenital hypothyroid screening, which you all have done in 2011 to 13, we will be doing in 22. Hopefully, we also would be able to do this. And all pediatric endocrinologists are dreaming to have this neonatal screening all over India to be fulfilled as early as possible with the cooperation of NNF doctors, Foxy doctors, general pediatricians. I think we require all your support to do this, not only in Kerala and also in all other cities. And like what sir said, many people in corporate, they all get this test done very easily. Now, even in medical colleges, they are aware and they are doing, but reaching the unreached, that is the rural area, what we need to aim. So I think we need to aim at these things, and we also have to talk to the government to reduce the prices, because even now doing even the filter paper, I'm sure it is costing more than 300 rupees per test, where the Kerala government is helping you all out. But all the governments in India have to follow that. And hopefully, if the price of these filter papers come down and assaying cost comes down, it would be much more easier to do these tests. That is the test part. Second is, as pediatricians, you need to learn how to do counseling once the diagnosis is done. Because when we diagnose congenital hypothyroidism and talk to the parents, they always say, does the thyroid come in children? That is the first question, because we've never heard. So you have to take extra 15 to 30 minutes and counsel them about the thyroid etiology, prognosis, and tell them if you treat them, their child will be as normal as you or me. That will reassure. Continued support, empathy, sympathy should be given to them, and always tell them not to go to alternative medical therapy, because many of them, they will start thinking like how adults take treatment for thyroid problems by doing yoga or Ayurveda or homeopathy. It can happen in children also. So I think we need to reiterate these parents that there is a deficiency, and at least for 3 years, they need to be given the thyroxine tablet. And the next goal, as Sir said, getting the tablet, crushing, giving it is very difficult. So we need to get the syrup form somehow. I think, again, this also needs a lot of work to be done here. And the follow-up, which all the pediatricians can do with the growth charts and the developmental scale assessments, which can help in the well-being of the child. And many times their IQ would become much more than 110 and 120 if you catch them early and treat them at appropriate time. I think with these few words, I would like to thank Dr. Vijay Kumar, Dr. Deepa, and whole team of Kerala IAP for doing this such a great job. I would like to congratulate you again and wishing you all the best for 100% screening of all newborn babies in Kerala, at least by the end of 2022. Thank you very much, everyone.
Thank you, ma'am. Now, may I invite Dr. Ananthakesavan, sir, Additional Professor, Department of Pediatrics, Government Medical College, Thrissur, past Vice President, South Zone, IAP, and National Vice President, ECHG 22-23, and member of National ACVIP. Sir, we invite you to felicitate the gathering.
Good evening. Okay, Chairperson Dr. Ragesh, today's chief guest Menon sir. I Kerala Karka Menon sir, Varana, Sangara Narayan Menon sir thaniyana. Terija madam, my past HOD is Dr. Parvati madam, formerly madam, KKP sir, past state president Dr. M. Venkatesan, all my senior colleagues, friends, and dear IAP family members. At the outset, I would like to congratulate the young and energetic team of endocrinology group of IAP Kerala. 10 to 15 young people from Periyaram to Trivandrum. They are doing a lots of work. And they are the most active sub-specialty camp in Kerala, because now they are all students, all patients are getting Mitai program. I think including land and institutions, they are getting free of charge. I think, I don't know what is this condition in other states. And recently also growth hormone also, people, about poor children are getting free of cost. It is available all over India, I don't know. But anyway, I think it's effort of under the leadership of Dr. Vijay Kumar and Dr. Riyas. So I would like to congratulate both Vijay Kumar and Riyas for their wonderful activities. Also, I would like to congratulate for the wonderful action plan promised by Dr. Vijay Kumar, my classmate, close friend. and I would like to wish all the success for this program. And before that, I want to say two incidents before this COVID season itself, because I am a little bit interested in pediatric neurology. I mean, so many children with development delay. An 18-year-old female girl suffered from Pannani as a mentally, physically crippled, bedridden child. That referred as a cerebral palsy. At that time, we don't do anything. It is a case of hypothermia. Second child was twin, one of the twin. So that twin, they are taken 1.5 year booster dose. One child is suffering from severe hypothyroidism. Other child is normal. There is one child for comparing to other child. So much delay, and the treating doctor not identified. I don't know. He missed this hypothyroidism at 1.5 years. There is comparison. It is one child is normal and it is abnormal. So my request to Dr. Vijayamar is that we have to include, we have to focus MBBS doctors also in Kerala. I think a very good number of people working in government sector and other private sector. When I had already told about teaching undergraduate students, but I think we have to focus general practitioners and MBBS doctors also in this program. I wish the program more success, and I would like to congratulate Dr. Deva Andujan for her sincere effort for this program. I wish them all the best. Thank you.
Thank you, sir. Ria sir was supposed to join our session, but because of some unavoidable circumstance, he is not able to. He has actually conveyed the wishes, and we all know that sir will be continuing the support and guidance for us in this. Now, may I request Dr. Johnny Sebastian, Secretary of IAP Kerala State, to deliver the felicitation.
Yeah. Thank you, Dr. Nitya. Good evening, all. Respected Chair and my dear friend, Dr. Rakesh, the Vibrant Secretary of IAP Thrissur, Dr. Pavan, State President, my leader and guide, Vijay Kumar Sir, Chief Guest of the Day, Dr. P.S.N. Menon Sir, former Professor of Pediatrics and a doyen in the field of pediatric endocrinology, Dr. Sheila Bhattacharya Madam, President ISPI, esteemed Speaker of the Day, Dr. Deepa, Dr. Anandakeshavan Sir, ACVIP member, seniors, Dr. Parvati Madam, Dr. K.K. Purushothaman Sir, all other dignitaries who have joined us today on this platform, and my dear friends. At the outset, I would like to congratulate IAP Thrissur for hosting this all-important inaugural ceremony of promise component, the screening of congenital hypothyroidism, which is very close to our dear President's heart. He has been advocating for this since years together, and we all know that screening of congenital hypothyroidism can contribute for the prevention of severe developmental delay associated with the condition, and is in fact a very noble project. And we all know if early diagnosis and early intervention can contribute to a near normal, very normal cognitive development of the infant. So this is actually what we can do successfully, and at least in our state, we should strive that we screen 100% newborns for congenital hypothyroidism. I wish this program all the very best, and I am sure that Dr. Deepa, as the coordinator of this presidential action plan, will take this forward successfully. Thank you. Jai Hind, JIA. Thank you.
Thank you, sir. With that, we have come to the end of inaugural session. Now it's time for academics. We have an excellent speaker for the day. Let me take the privilege to invite Dr. Deepa Anirudhan, today's speaker. Dr. Deepa Anirudhan is the Associate Professor of Pediatrics, Government Medical College, Thrissur, the consultant pediatric endocrinologist here. She is also the Executive Board Member of ISPE 2021-22. Madam is also the State Chairperson of Presidential Action Plan on Screening for Congenital Hypothyroidism, as mentioned. And of course, she is the apt person to enlighten us on this topic. Over to you, ma'am, for the talk.
Good evening. Is my screen visible?
Yes, ma'am.
Yes.
With your permission and permission of Dr. Vijay Kumar. Dr. Vijay Kumar, if we can just share the congenital hypothyroid screening video with all the, sorry to interrupt. Deepak, could you share the?
Yes, ma'am. Is the screen visible?
Yes, ma'am.
Yes.
Good evening. Good evening, respected PSN Menon sir, respected Shaila madam, Vijay Kumar sir, senior pediatricians, and dear friends. I would like to share a video on congenital hypothyroidism that was started by ISPE, one of the ISPE executive board members, to spread awareness among the general public on congenital hypothyroidism. This video is just only for 3 minutes, so please kindly watch.
Satya parents, வாங்க.
பாமா வணக்கம் டாக்டர். வாங்க, நீ எங்க உட்காருமா. சொல்லு. தேங்க்யூ டாக்டர். குழந்தை பிறந்து 4 மாசம் ஆகுது, ஆனா குழந்தை மந்தமாவே இருக்கு டாக்டர்.
ஆமா டாக்டர், பாலே சரியா குடிக்க மாட்டேங்குது. மோஷன் போய் 4 நாள் ஆச்சு.
குழந்தைக்கு தைராய்டு குறைபாடு இருக்கிற மாதிரி தெரியுது. குழந்தைக்கு பிறந்தப்போ தைராய்டு ஸ்கிரீனிங் டெஸ்ட் பண்ணீங்களா?
இல்ல டாக்டர், டெஸ்ட் எடுக்க தான் சொன்னாங்க.
ஆனா குழந்தை நல்லா தான் இருக்குன்னு நாங்க தான் டெஸ்ட் வேணாம்னு சொல்லிட்டோம் டாக்டர்.
அப்படியா? சரி. ஆமாங்க, இந்த டெஸ்ட் படி உங்க குழந்தைக்கு தைராய்டு குறைபாடு தான் இருக்கு. இதனால தான் உங்க குழந்தை மந்தமாவும் மோசம் போகாமலும் இருந்திருக்கு. குழந்தையோட மூளை வளர்ச்சிக்கு தைராய்டு ஹார்மோன் ரொம்ப அவசியம். அதனால குழந்தைக்கு தைராய்டு ஹார்மோன் மாத்திரைய உடனே கொடுக்க ஆரம்பிச்சிடலாம்.
டாக்டர், இன்னிலிருந்தே ஸ்டார்ட் பண்ணிடலாமா?
இதுவே லேட்டு. ஒரு நாள் கூட தவறாம இந்த மாத்திரைய தொடர்ந்து கொடுக்கணும். அப்புறம் எண்டோக்ரைனாலஜிஸ்ட், அதாவது ஹார்மோன் ஸ்பெஷலிஸ்ட் டாக்டர், அவங்கள போய் பாருங்க.
சரிங்க டாக்டர். ஏன் டாக்டர், குழந்தை பிறந்தப்போ இந்த டெஸ்ட் எடுத்திருந்தா சீக்கிரமா கண்டுபிடிச்சிருக்கலாம்ல?
ஆமா, கண்டிப்பா.
அனைத்து பெற்றோர்களும் தெரிஞ்சுக்க வேண்டிய முக்கியமான விஷயம் இது. நீங்க இப்ப பார்த்த குழந்தைக்கு 4 மாசத்துலதான் தைராய்டு குறைபாடு இருக்கிறத கண்டுபிடிச்சோம். உடனே ட்ரீட்மெண்ட் ஸ்டார்ட் பண்ணினா கூட இந்த குழந்தைக்கு இன்டெலிஜென்ஸ், அதாவது நுண்ணறிவு குறைவாக இருக்க வாய்ப்புகள் அதிகம். பிறப்பிலேயே தைராய்டு குறைபாடு வருவதை கன்ஜெனிட்டல் ஹைப்போதைராய்டிசம்னு சொல்லுவோம். இந்த கன்ஜெனிட்டல் ஹைப்போதைராய்டிசம் இந்தியாவில சுமாரா 1000 குழந்தைங்கள்ல ஒரு குழந்தைக்கு இருக்கும். தைராய்டு குறைபாடுடன் பிறக்கிற குழந்தை முதல் சில மாதங்களுக்கு மற்ற குழந்தைகளை போலவே இருக்கலாம். குழந்தை பிறந்த 3வது நாள்லயே ஃபில்டர் பேப்பர் டெஸ்ட் மூலமாக இதை கண்டுபிடிக்கலாம். இதுக்கு ஒரு சொட்டு ரத்தம் தான் தேவைப்படும். இதை ஸ்கிரீனிங் டெஸ்ட்னு சொல்லுவோம். அப்படி இல்லைன்னா சாதாரண பிளட் டெஸ்ட் மூலமாகவும் இதை கண்டுபிடிக்கலாம். அப்படி கண்டுபிடிக்கப்பட்ட ஒரு குழந்தை தான் சங்கீதா. சங்கீதா பிறந்த 3வது நாள்லயே ஸ்கிரீனிங் டெஸ்ட் மூலமா தைராய்டு குறைபாடு இருக்கிறத கண்டுபிடிச்சோம். இப்ப அவங்களுக்கு 15 வயசு ஆகுது. தொடர்ந்து டேப்லெட்ஸ் எடுத்துட்டு இருக்கிறதுனால இப்ப அவங்க நல்லா இருக்காங்க.
நல்லா இருக்கியாமா?
நல்லா இருக்கேன் டாக்டர்.
இவங்க தான் சங்கீதா.
நான் இப்ப 10வது படிக்கிறேன். பிறந்த உடனே ஸ்கிரீனிங் டெஸ்ட்ல எனக்கு தைராய்டு இருக்குன்னு டாக்டர் கண்டுபிடிச்சாங்க. தொடர்ந்து நான் டேப்லெட் எடுக்கிறதுனால நல்லா படிக்கிறேன். மத்த ஸ்டூடெண்ட்ஸ் மாதிரி நான் நல்லா இருக்கேன்.
ஒரு துளி ரத்தமே பரிசோதனை, தவிர்ப்போம் மனவேதனை.
If Dr. Sebastian doesn't mute me, I would like to thank Deepa for sharing this video. This video has been done by 2 of our executive members in Telugu and Tamil, and we also have translated it in Hindi. I think in next few months it would be translated in Malayalam, Kannada and all other languages, which every pediatrician should put in their clinics and allow the visitors, parents, whoever is in the clinic to watch this video, and even if they have missed the testing the thyroid, they should go ahead and do the thyroid test, and it is very educative for these parents, and they will also know that small baby has grown into a intelligent adolescent who is completely normal. Thank you very much, Deepa.
Thank you, ma'am, for those words.
Madam, you are muted.
Is my screen visible?
Not yet, ma'am.
Screen is visible, ma'am. Visible.
Oh. Thank you, IAP Kerala, IAP Thrissur, and Dr. Vijaykumar, this opportunity to present this module in front of this august audience. So this presidential action plan is on newborn screening for congenital hypothyroidism, 100% screening by the end of 2022. Congenital hypothyroidism, as you all know, is the most preventable cause of mental retardation in children. The incidence in India is 1 in 2,000 live births in India, compared to 1 in 3,000, 1 in 4,000 worldwide. And studies from the southern part of the country have shown that the incidence is roughly around 1 in 500 to 1 in 700, especially in South India. And only 1% of the congenital hypothyroidism can be diagnosed clinically in the neonatal period. This is because most of them are asymptomatic because of the maternal thyroid hormones. So they, unless we do screening, we may not be able to pick them clinically. So universal newborn screening should be practiced in all hospitals where the delivery is being conducted. So newborn screening is the birthright of every child. The Indian Society of Pediatric and Adolescent Endocrinology have come with the Indian guidelines for screening for congenital hypothyroidism. And the ISPE team has created a guidelines for this, which was published in Indian Journal of Pediatrics in the year 2018. It is in 2 parts, part 1 and part 2. And our very own Dr. Riya sir and Vijaykumar sir were also involved in this team. We'll go to a clinical scenario. So this is a 2-year-old boy with delayed development, constipation, and coarse facial features. So what is the diagnosis here? So diagnosis is clear. This is a case of congenital hypothyroidism. The child is already stunted and mentally retarded. You are very late in diagnosing this condition. So in congenital hypothyroidism, treatment should be started before 14 days of life to get a near normal intelligence. So it's very important that you diagnose them early and treat them early. And this should have been a diagnosis of the past. It's not great to diagnose a congenital hypothyroidism. Actually, we should feel sad for this child. So the learning objectives of this module is importance of newborn screening, what are the samples to be taken, interpretation of the results, evaluation, management, and follow-up of children with congenital hypothyroidism. Why do we need screening? So treatment for congenital hypothyroidism, best results are obtained when the treatment is initiated within the first 2 weeks of life. They get almost a near normal intelligence. But if the treatment is delayed, even up to 30 days, they have a mean IQ of 106. But in children where the treatment is initiated beyond 3 to 6 months, the mean intelligence quotient is only 70. This is because the child has already become, this shows the child has already become mentally retarded. So our aim is to screen them early and treat them early. So for a newborn, the thyroid screening can be started either at the time of birth from the cord blood or 48 hours later. So why is this so? So we all know that TSH rises within 30 minutes after birth, reaching to a very high value, even up to 60 or 80. That is known as the TSH surge. And this surge slowly comes down by around 48 hours of life. In some babies, this surge can take up to 96 hours also to come down. So that should also be kept in mind. So that is why the test should be done only after 48 hours. Either it has to be done right at the birth from the cord blood or after 48 hours of life. If you see this chart, you can see that the TSH surge in preterm babies, which is shown by the dotted line, the surge is less compared to a term baby. Also, the rise in T3 and T4, which follows, is also very, very less in a preterm baby compared to a term baby. So what are the samples which has to be taken? So I have already told that it is either the cord blood screening or a postnatal screening. So but both these methods have their own advantages and disadvantages. Cord blood screening is painless and it is not affected by neonatal surge, whereas postnatal screening is painful and can affect the neonatal surge, can be affected by the neonatal surge. And cord blood screening can be done in all neonates right at the birth without any additional equipment involved, and report is usually ready by the time of discharge. But postnatal screening may be missed in children who get discharged early, and report may be delayed, or you have to recall them for another repeat test. Then in case of cord blood screening, other metabolic disorders usually cannot be screened because they need at least 48 hours for the baby to feed, and then only we can detect in the postnatal post-screening test. Then round the clock personnel is needed for cord blood screening, whereas postnatal screening sample collection can be done during the morning hours. So both of them have their own advantages and disadvantages also. So what are the different screening methods? We can do either a primary TSH screening or a primary T4 screening. Primary TSH assay is the one which is usually followed everywhere, most of the places, and it is more sensitive and cost effective. But should remember that we can miss babies with delayed elevation of TSH. That is the premature babies and sick babies. We can see that they have a delayed elevation of delayed elevation as well as reduced amplitude of TSH. They can also miss babies with central hypothyroidism because in those babies the TSH may be normal, only the T4 may be less, and that we are not screening by the primary TSH assay. The other method is a primary T4 assay. So it is done in some parts of the world. Central hypothyroidism could be picked up by the primary TSH assay, but it can miss neonates with compensated hypothyroidism. So compensated hypothyroidism, T4 may be normal and TSH may be elevated. So unless you do the TSH, you may not be able to if you're doing only the T4, this may not be picked up. Then values will be low in preterm babies, sick babies, and babies with thyroxine binding globulin deficiencies. All of them will have low assay, and we may be diagnosing them, false positive diagnosis may be there. So primary TSH screening is adopted by most centers worldwide, and it is recommended for India. So how do we screen? We all know that in Kerala, we have been screening babies for congenital hypothyroidism by the postnatal heel prick test. And for the and usually along with congenital hypothyroidism, we also screen for other diseases like CAH, galactosemia, and G6PD deficiency. So this is the screening card which is available in our hospital, where you can see the 4 wells are there. So blood is taken by the heel prick sample and introduced into these wells. And the complete details of the babies, then this card is dried and it is sent to the regional reference center, where usually the sample, usually the result is obtained within 7 days. And the babies who have abnormal results are being recalled. This is the method of collection of blood by the heel prick. By the personnel, usually it is a sister who has to be trained in this. Blood is collected by the heel prick method, either the lateral or medial part of the heel, and is squeezed so that so as to introduce it into these wells on the filter paper. And it is to be ensured that the blood sample is collected properly, otherwise you may get false negative results. Some group of babies need a second screening after 2 to 4 weeks. They are premature babies, low birth weight babies, sick babies, babies with Down syndrome, twin or multiple births is there, or if the first sample is taken after transfusion. It is essential that no newborn should be sent home without a congenital hypothyroidism screening. So, who are the high-risk neonates, which we have just seen? They are the preterm babies, small for gestational babies, sick babies, either having sepsis or asphyxia, twins, particularly monozygotic twins. They have an attenuated surge of TSH, as we have seen. Then there is a immaturity of the hypothalamic pituitary thyroid axis. Usually the maturation of this TSH axis will take up to 3 to 4 weeks. And use of iodine and antiseptics, because preterms are extremely sensitive to the use of iodine in the mother, especially for the pre-delivery use of iodine. They can develop either hypothyroidism or even hyperthyroidism. Then there is something known as a sick euthyroid syndrome, which is characterized by a low T3, low T4, and a normal to slightly low TSH levels, and a low TBG levels. So all this contribute to that the TSH may not be as high as expected, and T4 may be low in these children. So if you take a screening test actually with TSH, you are likely to miss these children. Twins, particularly monozygotic twins, are important because one may be normal and one may be abnormal. One may be having congenital hypothyroidism. And if the cord blood is taken, the blood may be mixed, and finally the TSH may come as normal. So that is why twins, again, second screening should be taken. Then we had mentioned also about Down syndrome children. So Down syndrome children, it is important to know that there's a high incidence of congenital hyperthyroidism as well as subclinical hypothyroidism in children with Down syndrome. And because of they are more sick due to the congenital anomalies and problems during the newborn period, they may not have a expected rise in TSH as we expect in the case of a normal child. So that is why all Down syndrome babies also require second screening at 2 to 4 weeks of age. So all high-risk babies need a second screen. How do we interpret this results of the screening and confirmatory samples? So we have taken the sample, sent to the reference laboratories. What are the cutoffs to be taken? TSH value more than 20 is recommended as the cutoff for recall for both cord blood and postnatal sample after 48 hours of age. If we take the sample within 24 hours of age, the TSH cutoff is 34. So ideally it should be taken only after 48 hours of life. If the result is in whole blood unit, it has to be converted into serum unit by multiplying with 2.2. So why this is so? Because The filtered paper samples are always expressed in whole blood units. And the method of TSH estimation in whole blood and as well as the venous sample are different. So the whole blood, the sample taken from the whole blood needs a correction factor for the hematocrit. That is why we had to multiply the whole, whatever value we get in the filter paper by 2.2 to convert it into serum unit. All our cutoffs are actually in the serum units. So this is very, very important. Otherwise, you may miss children thinking that the screen is normal. If the screening value is positive, the child is recalled and confirmatory venous sampling for TSH and T4 or free T4 is done. So how do we interpret? We need to know about a few terminologies. So when do we call as elevated TSH? Before 14 days of age, a venous TSH of more than 20, and after 2 weeks, a TSH of more than 10 is considered as elevated TSH. Low T4 or low free T4 we say when the T4 is less than 10 or a free T4 is less than 1.17. And very low T4 or very low free T4 is T4 less than 8 or free T4 less than 1.1. So in the screening sample, if you get a TSH more than 20, either by a heel prick or cord blood, the baby has to be recalled. And then do a total T4, free T4 and TSH. Either of these is, whichever test is available in your laboratory, you can use them. Either TSH with any of the T4 value, either a total T4 or a free T4. Free T4 is always better if done in a properly, if done in a good lab. So, so if your the baby screen sample, TSH is more than 20, we recall the baby. And if the TSH is more than 40, the baby has to be recalled immediately within 72 hours. And we had to do a physical examination and confirmatory venous sample for T4 and TSH. And if the TSH value is more than 80, start immediate treatment without waiting for the results. If it is between 40 and 80, you can wait for the results for starting the treatment. So if it's more than 80, take the sample, immediately start treatment. If the TSH is between 20 and 40, the baby has to be recalled in the second week, that is between 7 and 10 days. Again, physical examination and confirmatory venous sample for T4 and TSH has to be taken. If the baby has a very low free T4, that is less than 1.1 or a free T4 or T4 less than 8, irrespective of the TSH, you have to start the child on treatment. Or if the baby has a low T4, that is less than 1.17 or free T4 or a T4 less than 10, along with a raised TSH, more than 20 within 2 weeks or more than 10 beyond 2 weeks, again you have to start treatment. So very low free T4 or T4, you can start treatment irrespective of the TSH. Otherwise, low T4 with the raised TSH also, you can start the treatment. Suppose the free T4 or free T4 has come as normal, only raised TSH is there within more than 20 within 2 weeks. Then you can repeat the test, TSH, repeat the thyroid function test after 2 weeks. And persistent elevation of more than 10 beyond 3 weeks with a normal T4 or free T4, again you can start the treatment. And these babies, all the babies require reassessment after 3 years. Again, this is the same algorithm which I have mentioned. You take the heel prick or cord blood, first screen. TSH has come as more than 20, take a confirmatory venous sample for TSH and T4. And more than 40, recall them within 72 hours. Between 20 and 40, recall them in the second week, that is 7 to 10 days of age. If the TSH is less than 20, it is considered as normal. So after that, you take a confirmatory venous sample. So in the confirmatory venous sample, a low free T4 or a T4 with a high TSH, start treatment. Very low T4 or free T4, irrespective of TSH, again, start treatment. Normal T4 or free T4 with a high TSH, start treatment if TSH is 10, even after 3 weeks. And if everything is normal, the baby needs no treatment. If the screening value is very high, more than 80, Thyroxine can be started while awaiting the confirmatory results. You take the sample, immediately start the child on treatment. So how to evaluate a child with primary congenital hypothyroidism? The child has features of primary congenital hypothyroidism. So congenital hypothyroidism could be either permanent, transient, or other less common causes like central hypothyroidism. Among the permanent causes, mainly it is the structural problems, that is ectopic, either ectopic thyroid, agenesis, or dysgenesis, or it could be synthetic function, that is the dyshormonogenesis. There can as well be transient forms, which are also very common. Either it can be due to maternal thyroid antibodies, or it can be due to iodine exposure, or even iodine deficiency can lead to transient hypothyroidism, and sometimes maternal antithyroid drugs can lead to transient hypothyroidism. So it's important to differentiate between these two conditions because children with permanent hypothyroidism needs treatment for life. Whereas transient hypothyroidism should be treated for 3 years because that is the period of critical brain development. You can reassess them at the end of 3 years and then decide whether to continue treatment or stop treatment. So it's better not to interrupt any treatment, reduce the dose, or not stop treatment before the age of 3 years, unless the child is having features of hyperthyroidism or clinically having hyperthyroidism or TSH2 suppressed. So you have to take a detailed history and physical examination. You have to ask history of a consanguinity, detailed perinatal history for any asphyxia, sepsis, and you have to ask for maternal any thyroid disorder. Mother may be having in the remote past also. Mother may be having antibodies which can affect the thyroid function of the child. Look for any type of dysmorphism. We know that a lot of conditions, syndromic conditions, are associated with congenital hypothyroidism. So also there can be so many other primary congenital hypothyroidism can be associated with many other anomalies, including cleft lip, cleft palate, congenital heart diseases, hypotonia, micropenis, or renal abnormalities. We should remember that there is a high incidence of congenital heart disease and renal anomalies, especially more than 3 times the general population in children with congenital hypothyroidism. And cleft lip, cleft palate, and micropenis and all may point towards a central hypothyroidism. And some hypotonia is seen in syndromic babies. Then following this, once you have assessed the child clinically, then we have to go for a imaging technique, that is ultrasound thyroid and a radionuclide scan. Can be either a technetium 99 or iodine 131. So usually we use technetium 99 scan. This is for identifying the etiology and also for counseling the family. You can tell about the nature of the illness right from the beginning if you do these investigations early. Hearing screen should be done for all babies. Now that we, as a part of our comprehensive newborn screening program, we are also doing this hearing screen, but it is particularly important in case of congenital hyperthyroidism because thyroid hormone is required for the development of cochlea and the auditory function and all. So there is a high incidence of hearing impairment, even if you exclude the dyshormonogenesis, the Pendred syndrome, but otherwise also there can be high incidence of hearing impairment. So the imaging, what are the imaging techniques that we use? It can be either ultrasound thyroid, which is easily available, but it is observant dependent. That is, the sonologist should be very experienced to do the thyroid imaging in a newborn. Sometimes false positive results are sometimes got. Many times we have got like that. And ultrasound thyroid cannot detect ectopic thyroid. Only with the help of Doppler, ectopic thyroid can be detected. And radionuclear imaging, as I mentioned, technetium 99 is the one which is used very common, but it is available only in referral centers and needs IV administration. Within 15 minutes of IV administration, we can take the scan. It is, we should remember that it is not at all having radiation. The risk of radiation is very, very less. And it is safe in children and clearly establish the diagnosis if you do right from the birth. It is a very safe investigation. And it should be done either before starting treatment or within 7 days of starting thyroxine. So you need not actually wait for these investigations to be done. You can start treatment and do these investigations at a later time. If no resource constraints are there, you can do both ultrasound and radionuclide scanning at diagnosis. So that both of them are complementary actually. The first one shows a normal thyroid scan, you can see that you can identify the normal gland here, and these are the salivary glands, which again takes up the technetium dye. This is the age. Second picture is the picture of agenesis. There is no thyroid tissue seen over the neck, but you can see it is concentrated over the other areas like salivary glands. And the third one is the ectopic thyroid gland. You can see that it can be located anywhere from the base of the tongue right up to the thyroid cartilage. So a single small gland is there, that is the ectopic thyroid. But the golden rule is that imaging should never be the reason to delay the initiation of treatment. If treatment could not be done at the time of diagnosis of congenital hypothyroidism, it can be done at 3 years after stopping treatment for 4 weeks. So imaging is not a priority, treatment is the priority, and it should be started as early as possible. You can identify the etiology using the thyroid imaging by combining both the thyroid scan, that is technetium scan, nuclear scan, as well as the ultrasound thyroid. So in the initial thyroid scan, there is uptake at the base of the tongue or anywhere along the path of the descent of the thyroid. It is a lingual or it is a ectopic thyroid. If there is no uptake on a thyroid scan, an ultrasound also, the gland is not visualized, it is agenesis. But if there is no uptake on the radionuclide imaging, but there is an uptake on, but the gland is seen on ultrasound, this condition is known as apparent athyrosis. It is seen if there is a maternal receptor blocking antibody, such receptor blocking antibody is there, or the mother is on antithyroid drugs, or there is a iodine uptake defects and all. This is possible. So ultrasound shows a thyroid and there is no scan uptake on iodine technetium 99 scan. If there is increased uptake, you can see that there is an enlarged gland. So there is an increased uptake on thyroid scan with an enlarged gland ultrasound. It is a dyshormonogenesis or a synthetic defect. And if sometimes thyroid scan can be normal or normal uptake with a normal ultrasound in case of transient congenital hypothyroidism. So after diagnosing, the priority is to treat the congenital hypothyroidism. So start with tablet thyroxine at 10 to 15 micrograms per kg. You should advise them to crush the tablet because liquid forms are not available in our country, and it should be mixed with breast milk and given in the early morning every day till 6 months of age, and in water after 6 months of age. It's important to give thyroxine tablet at the same time every day. Do not give iron, calcium, or soya along with thyroxine because that can affect the absorption of thyroxine. Then once you started on treatment, if the you should also remember that if the T4 levels are in the normal range, you can even start at a lower dose, that is around 10 microgram per the lower spectrum, you can even start the treatment if the T4 levels are normal. So when should we repeat after you start treatment? So repeat T4 or free T4 at 2 weeks and T4 and TSH at 4 weeks. The aim is that T4 should normalize at 2 weeks and TSH should be normal by 4 weeks. Transient elevation of TSH is possible sometimes due to pituitary resistance. That happens in case of agenesis or dysgenesis of thyroid. Sometimes that is like transient pituitary resistance because it is exposed to a high TSH level. So that is not, sometimes that is not a problem. You always try to normalize TSH within, normalize T4 within 2 weeks, and it should be maintained in the upper half of the reference range. And further follow-up is by biochemical follow-up. You adjust the dose according to the thyroid function tests. So TFTs have to be done every 2 months till the age of 6 months, and every 3 months from 6 months to 3 years, and every 3 to 6 months till the end of the growth. And whenever you change a dose of the thyroxine tablet, the TFT has to be repeated within 4 to 6 weeks. Always use age-related cutoffs. So these cutoffs have been given in the ISPE guideline. So it's better to save these cutoffs in your mobile phone so that whenever in doubt, you can use that. These are the Indian reference ranges. And it's important never to use the adult reference standards. They are different from pediatric standards. Usually the whatever labs prescribe are always the adult standard. So don't use that, use our age-related cutoffs. So how to follow up these children after starting treatment? So TSH and T4 should be done as mentioned And T4 should be maintained in the upper half of the normal range. That is very important because the long-term intelligence is related to the T4 levels most of the time. And TSH should be in the lower half. Growth and puberty should be followed up in these children. The height or length and weight has plotted at each follow-up in a growth chart. And bone age may be assessed if the child is not growing well. Development should be assessed at each time. And in spite of efficient treatment, sometimes if the patient is not very compliant, they can have developmental problems, and it should be documented at each follow-up. And if there is if there is a delay in development, or if you see or the treatment has been started at a late age, you have to send the patient to a developmental therapist so that optimum outcome is being received. Head circumference should also be monitored at each follow-up. So suppose we see a high TSH on follow-up, always check the compliance to thyroxine. That is very important. So many times we have seen that during the COVID pandemic, patients are not coming for follow-up, and they think that if they are not seeing the doctor, there's no need to give thyroxine or like that. So we have seen many patients who have not stopped thyroxine over the past 1 to 1.5 years. So that is very important, high TSH on follow-up. And always inquire the technique of administration. They may be administering with some food items or with drugs which can impair thyroxine absorption. It's not a problem in case of babies within the first 6 months. There you can give the medicine with milk. Then high TSH and normal T4 levels. When does this happen? Suppose we have taken the sample within 4 hours of thyroxine intake. So it's better that either you will take the sample 4 hours after ingestion of thyroid tablet, or on that particular day, ask them not to take the thyroid tablet. And then after taking the sample, then they can take the on that day only. You can tell the parents you can do like that. So sometimes you can, if the patient has taken thyroid tablets prior to the sampling, there can be normal T4 levels. The TSH will remain high, but you can get like that. Then poor compliance with multiple doses before sampling. So they have not taken for many days. Within 2-3 days, they have taken multiple doses, 1 or 2 doses extra. So this can happen. Then there is sometimes pituitary resistant to T4, as I have already mentioned. So how to recheck permanency of thyroid? So you adjust the dose according to the thyroid function test, and continue the treatment for 3 years. And at the age of 3 years, if the initial evaluation has not been done, complete evaluation has not been done, you can stop the tablet for 4 weeks at 3 years. So this can be either, if the dose is usually less than 25 or less than 25, we can even abruptly stop the thyroid tablet and see, or you can reduce the dose by 50% every 2 weeks, and then slowly taper and stop the drug over 4 weeks. At the end of stopping the drug, you can take the TSH after 4 weeks. And if the TSH is more than 10, do the imaging if not done earlier. So that is the best time you can do technetium imaging. So technetium uptake is good only if the TSH is high. Otherwise, if the TSH is suppressed, there won't be any uptake. So you can do a technetium scan at that point of time, and ultrasound also. And if the TSH is between 5 and 10 and T4 is normal, the child requires only frequent follow-up clinically and biochemically. Plot the growth of the child, look for symptoms, constipation, and just follow up the child. You don't need to start the treatment, provided the T4 is normal. If the TSH is less than 5 and T4 normal, it's a transient hypothyroidism, and the baby needs only follow-up. So these children may require, initially for the first 1 year, every 3 months, TFT can be done and followed up for 1 year. After that, if there is no problem, again, the frequency can be reduced once in a while and even stop altogether. Re-evaluation is not required if proven permanent hyperthyroidism is there on the nuclear scan. So initially you have done a nuclear scan and seen that there is agenesis, dysgenesis, or ectopic thyroid, then the diagnosis is already clear. You don't have to stop the medicine at 3 years. The diagnosis has already made, and you counsel them that they have to take lifelong thyroxine treatment. And if there is TSH more than 10 on follow-up beyond 1.5 to 2 years, at any time during the follow-up, the TSH rises more than 10, again, it is an indication that it may be a permanent hyperthyroidism. So the conclusions are, every newborn should be screened for congenital hyperthyroidism. It's a birthright of every baby. Screening can be done by either cord blood or postnatal heel prick sample within 48 to 72 hours but not later than 5 days of life. In sick babies, sometimes you can wait until 5 days to take a sample. Otherwise, it is, even for preterms, very low birth, all babies, postnatal sample is taken within 48 to 72 hours. Infants with screening of TSH more than 20 or more than 34 within 24 to 48 hours should be evaluated with a confirmatory venous sample, and venous TSH more than 20 within the first 2 weeks or after 10, after 2 weeks of life with a low T4 suggests that there is a primary hypothyroidism. Thyroid imaging is desirable in primary congenital hypothyroidism, but should not delay the treatment. If there is a delay in getting this treatment, you should immediately start the treatment. Treatment is started with levothyroxine 10 to 15 microgram per kg per day as a single dose, and education of the family is very important regarding compliance, follow-up, and administration of the thyroid tablets. And maintain T4 in the upper half of the normal range and TSH in the lower half of the normal range. Re-evaluation of permanency can be done at 3 years if you are suspecting transient congenital hyperthyroidism. But if it's already there is agenesis proven by ultrasound and all, there is no need to re-evaluate the child unnecessarily at 3 years. With this, we'll go to a few case scenarios. This is the second part of the module. So the first case, a 3-day-old newborn of weight 2.8 kilos. The neonatal screening done by Heelbrick on a filter paper showed a TSH of 80. So what is your interpretation? And should this baby recall for screening or confirmatory test? So our cutoff within 2 weeks, cutoff is 20, isn't it? The child has a TSH of 18. So should this child be recalled? So the answer is that the child should be recalled because filter paper samples are often interpreted in blood units. So if the result is in whole blood units, it has to be converted into serum unit, as I have mentioned previously, by multiplying it with 2.2. So here the actual TSH value is 39.6, which is very high. So this baby should be recalled for a confirmatory venous sample. At what time? Since it is between 20 to 40, after 7 to 10 days of life. So confirmatory venous sample on day 10 shows a TSH of 18 and free T4 of 1.7. So again, we are in a fix. So our cutoff here is 20, free T4 is normal. So should we again ignore this, or should we again screen this baby? Answer is yes. You don't borderline high TSH also should be screened again. So even with a normal T4. So this can happen in delayed maturation of the hypothalamus pituitary axis, a transient or a permanent congenital hypothyroidism. Can also sometimes present like that if there are stress factors, and sometimes thyroid hormone resistance can be like this, or even Down syndrome. They can also have a borderline high TSH like this. So the plan is that it should be also taken like a elevated TSH and recheck TFT after 2 weeks. So if it comes as normal, there is no need for any treatment. But persistent elevation of TSH more than 10 beyond 3 weeks with a normal T4, they have to start treatment. And trial of therapy has to be given at 3 years. So this may be most likely transient hypothyroidism because of the borderline TSH and all. Suppose treatment is justified at the first instance if follow-up is likely to, if they are coming from a very backward place, and unlikely to be, it's very unlikely that they'll come for follow-up. It's always better to start treatment instead of otherwise they may come to you later at 2 or 3 months of age with frank hypothyroidism, and start treatment and then ask them to follow up frequently. Low T4 with borderline high TSH also needs treatment. At any rate, that requires treatment. So going to the second case scenario, full-term normal female baby, the cord blood TSH has come as 150. How do you manage this baby? So again, we know that the baby has to be recalled immediately because the TSH is more than 40, and you have to start the treatment. Do a physical examination and other routine tests should be taken, including a hearing test and all. And start treatment immediately without waiting for the results as TSH is more than 8. So this again, the same thing in a nutshell. Hot blood or TSH, if it's more than 20, or you have to do a venous confirmatory venous sample, and TSH more than 40, as in this child, physical examination and take a confirmatory sample for T4 and TSH and start treatment immediately since the TSH is more than 80. If it's a borderline thing, again, you can do after 2 weeks and again start. If it's high TSH, more than 10, even after 3 weeks with a normal T4, you can start treatment. So what further evaluations are needed in this baby? So the confirmatory venous sample in this baby showed a TSH of more than 500 and a free T4 which is very low, 0.6. So this is a primary congenital hypothyroidism. Physical examination, hearing evaluation, and if possible, thyroid imaging, ultrasound, and technician 99 CT scan should be taken. And this is a picture which shows ectopic thyroid, because the commonest cause of congenital hyperthyroidism is thyroid dysgenesis is ectopic thyroid. And treatment should not be delayed if this test cannot be done immediately. Again, treatment, start L-thyroxine tablet at 10 to 15 microgram per kg per day. So this child, 37.5 microgram was started per day, it comes to around 13.4. And always the technique of administration, need for compliance and follow-up should be explained. And if possible, a written handout should be given, telling the patients about the prognosis. We have, in ISPE, we have handouts for congenital hyperthyroidism. So that can be, that is available in the ISPE website. So if you want, you can take a copy and then give to the patients. Then ask to follow up after 2 weeks with T4 and TSH. So after 2 weeks, the child came with a TFT, TSH is 62 and free T4 is 1.9. Should we increase the dose as TSH is high? After 2 weeks, should we increase? So the answer is no. Why? Because TSH normalizes only by 4 weeks. Seeing this TSH, we should not hike the dose further. T4 should be normal by 2 weeks. And since we have seen that this free T4 is in the upper half, so you don't have to just follow up the child. You don't have to increase the dose any further. And age-specific cutoff should be used by interpreting TFTs, not the adult cutoff prescribed in the labs. Again, this is the same algorithm which I have told that. So this child comes here. So T4 normalizes by 2 weeks, which happened to this child. And we expect a normalization of TSH only at 4 weeks. So the dose of the child should not be, need not be increased. We can evaluate after another 2 weeks and then again repeat the whole thing. And again, if TSH is above the age-specific cutoff, we can increase the dose. So they have to be followed up biochemically. This is the case scenario 3. The laboratory results of a 6-day-old preterm newborn. So the TSH has come as 2.1, T4 as 5.3. So what are the DDs of low T4 and a normal TSH? So we have seen that low T4 and a normal TSH could be because of the transient hypothyroxine premature babies. They have an attenuated rise of T4 and even TSH. It could be due to the sick euthyroid syndrome. Like babies who are sick can have low T3 and T4 can be there. Then sometimes in TBG deficiency, you can get a low T4 and a normal TSH. So in that case, a free T4 will be normal. So free T4 will be normal, T4 will be less in such babies. So sometimes if there is a doubt, repeat test, you can do a free T4 along with TSH. Primary hypothyroidism with a delayed rise of TSH, that which occurs in preterms of SG babies also can be there. So it can be also a case of central hypothyroidism. So only follow-up of this baby, maybe can repeat the TFT after 2 weeks. And again, if free T4 and TSH after 2 weeks, and then decide on treating this child. So we'll go to the 4th case scenario. A term baby born out of breech extraction, weight 2.5 kilos at birth. On examination, the child has a microphallus, that is, stretch penile length is only 1.5 centimeters with a well-developed scrotal sacs and bilateral undescended testes. Baby has an episode of hypoglycemic seizures on day 4 after birth. So his screening results showed a TSH of 4 and he was not recalled. So So in spite of child having multiple seizures, so whenever you see a child with microcephalus with or without an undescended, with or without an undescended testis and hypoglycemic seizures and all, always you should suspect can be a multiple pituitary hormone deficiency because multiple hormones are involved here. So as a part of evaluation, TFT was repeated and which showed a TSH of 1.2 and a free T4 of 0.7. So what do you call this? Because free T4 is very low with a normal TSH. This is the baby. You can say that there is micropenis. So this is a case of central hypothyroidism, a normal TSH with a low T4 value. And this child has low T4 and low TSH and low T4. This is in favor of central hypothyroidism. Child has also features of panhypopituitarism. The child has features of gonadotropin deficiency also. So other pituitary hormones should be measured, like growth hormone, serum cortisol, and gonadotropins should be measured, and multiple MPHT should be documented at that time. And MRI should be done to rule out structural anomalies and pituitary abnormalities. Whenever you diagnose MPHT, this has to be done. And replace thyroxine, growth hormone, and hydrocortisone. The word of caution is that in case of multiple pituitary hormone deficiency, cortisol deficiency should be detected and treatment should be initiated at least 48 hours before initiating thyroxine. Otherwise, the thyroxine, the LT4 levels increases the metabolic rates and renal clearance, and this can precipitate adrenal crisis. So the first one, replace hydrocortisone. After that, you can replace thyroxine. Then, if required, recurrent hypoglycemia is there, you can even replace the growth hormone. And titrate the dose based on free T4 levels. Free T4 or T4 levels, because you should never look at the TSH in this case, because the TSH will be always suppressed. It will be in the range of 0.0 or 0 length. Always in central hypothyroidism, titrate the dose based on free T4 or the T4 levels. This is the last case scenario. A newborn baby born with Down syndrome had a cord blood TSH of 60. As per the SPE guidelines, what should be done? So cord blood TSH is normal because our cutoff is 20. So, but since this is a Down's baby, we should repeat the thyroid function test at regular intervals. So at Down syndrome, at birth should be taken. Repeat the screen test at 2 to 4 weeks of age and at 6 months, and every year at 1 year, and every year after that yearly it should be done. So this is how a baby with Down syndrome should be followed up. There can be falsely normal newborn screening can be there sometimes. You do initial screening test, you can get a falsely normal screening test. So in case of preterm babies, very low birth weight babies, critically ill newborns, post-transfusion, monozygotic twins, or sometimes it can be due to technical errors in collection, errors in transportation or recall rates. All these technical errors are bound to happen. So in spite of the best, in spite of screening, even in the Western countries, 5% of the cases can be missed despite screening. So it's very important to know that. So we'll go to a case. So newborn screening is not 100% foolproof. And this is a 7-year-old girl with a cord blood screening was negative, not suggestive of any congenital hypothyroidism. But the child presented at 7 years with delayed development, short stature, coarse facies, and was referred as mucopolysaccharidosis. TFT was done at that time, which showed a TSH of 150 and a T4 of 3, which is very low. So what happened to this baby? So initially, the newborn screening, this shows that newborn screening is not 100% foolproof. Even after starting the treatment, the child's facies and all has improved. But we all know that the intelligence of the child is mentally retarded. So whenever there is a clinical suspicion, always remember that we should repeat the thyroid function test. So newborn screening is the right of every baby, either cord blood or heel prick sample, and filter paper samples are reported in whole blood units, and it should be interpreted accordingly. Always remember to multiply filter paper samples by 2.2 to get the serum units. The main purpose of newborn screening is to pick up primary congenital hypothyroidism, which can lead to permanent intellectual disability. Prompt evaluation, early and adequate treatment, and education are the keys to successful management of congenital hypothyroidism. In case of raised or borderline increase in TSH with a normal T4, follow-up testing can be done after 2 weeks and treatment started if the TSH is more than 10 on follow-up. Second screening is valuable not to miss babies who are at risk for delayed elevation of TSH. The risk groups we have mentioned. Wherever there is a clinical suspicion of hyperthyroidism, this is very important. TFT should be repeated. It is such a very cheap test, and at the slightest clinical suspicion, we should do a thyroid function test, which have an implication for a lifetime actually for the baby. So even if the initial newborn screen test is normal, you should repeat that test. I express my sincere thanks to the Indian Society of Pediatric and Adolescent Endocrinology, ISPE, for the module, and Dr. PSN Menon sir, Dr. Vijaykumar sir, and Riya sir for help in preparation of this module, and Dr. Nitya for all the technical help and support for this module. So our IAP Kerala Presidential Action Plan 2022 is screening for congenital hyperthyroidism, and we have our IAP President Vijaykumar sir and Secretary Dr. Johnny Sebastian sir, and we have patrons Dr. PSN Menon sir and Riya sir, and we have zonal coordinators for the program, Dr. Shija Madhavan for the South Zone, Dr. Nitya for the Mid Zone, and Dr. Priya for the North Zone. And aim of the Presidential Action Plan is 100% newborn screening and mandatory follow-up of children with congenital hyperthyroidism. So screening, not only screening, and appropriate follow-up of the children is also essential for optimal outcome. So we have plans for creation of modules for congenital hyperthyroidism screening, which we had launched today, and widespread dissemination of this information to the pediatricians of all IAP branches. And there's a plan for conducting TOT for pediatricians in health service, because majority of the newborn screening is, although majority of the deliveries are happening in the private sector, it's important to conduct workshops in the health sector through NHM also to encourage them for appropriate screening and follow-up. The modules on congenital hyperthyroidism should also be disseminated to general practitioners, because they are also in the predominantly in the health service. And the NBS program is currently running in government hospitals through RPSK, is to be extended to private hospitals with the help of national health missions, so that all newborns in Kerala should get a free newborn screening. So it should not be a choice of the patient to do a newborn screening. It should be done compulsory. The widespread dissemination of the mandatory screening for congenital hyperthyroidism to be disseminated to the general public through All India Radio, FM stations, newspapers, magazines, etc. So I urge all pediatricians to disseminate this information. What we got from the general public is that they are not very aware of congenital hyperthyroidism. The important they don't know, leading to a loss of follow-up and irregular treatment and things like that. So that has to be done. And we are planning a follow-up booklet for children diagnosed with congenital hyperthyroidism for 1 year, at least for a period of 1 year, to be planned with the help of NHM, which contains information for parents on congenital hyperthyroidism, which also contains key milestones, andrometry, thyroid functions, dose, etc. So which will help the physician or the pediatrician to follow them appropriately. And the World Thyroid Day is on May 25th, and this emphasis on this year's will be on congenital hyperthyroidism, should be given for congenital hyperthyroidism, and the general public to be made aware about this CH screening at various mass media mentioned above. Thank you for patient listening, and I thank Vijaykumar sir for this opportunity, and IAP Thrissur as well, IAP Kerala for this opportunity. I urge that all the pediatricians to make this presidential action plan a big success by early detection and follow-up of newborns with congenital hyperthyroidism, not to miss any single cases, actually, which can cause a lifetime of intellectual disability for the baby. So with these words, I conclude my talk. Thank you for patient listening.
Thank you, ma'am, for the much informative and excellent session. I think now the session will be open for discussion. We have a couple.
Can I ask one doubt?
Yes, ma'am.
Excellent presentation, Deba. I have a silly doubt. You said that in sick euthyroid, the T3 and T4 are low. But why do you call it euthyroid then? Is it only low normal or?
Actually, they are euthyroid, but because of the stress and because of the immaturity of all this because of the stress factors and immaturity of the axis and all, the T4 and T3 are apparently lower. They are actually euthyroid and they usually don't require treatment unless the free T4 is too less. They usually don't require any treatment. Even preterm babies with all the signs in hypothyroxemia also don't require treatment.
So you repeat the test after some time. Do you repeat that?
Yes, ma'am. So can be repeated after 2 weeks.
Okay.
We have a couple of questions in the chat box, ma'am. How much fasting time is required before giving thyroxine? That's the first question. And after taking the drug, for how much time breastfeeding should be avoided?
Okay, so breastfeeding in case of newborns or within the first 6 months, the thyroxine tablet can be given with breast milk. There is no need to stop breast milk or withhold for some time or not. So it can be given along with food. There's no problem. Beyond 6 months, it can be given with water. And there's nothing like fasting before thyroxine. In older children, they had to have at least a half an hour to 45 minutes before taking food. That is the only thing required.
Dr. Vijaykumar, sir, is left.
Sir, I am listening, sir.
Vijaykumar, if time permits, I got a few suggestions about the program implementation
Yes, sir,
part.
yes, sir.
And the last slide of Deva, I would like to add a little more of this thing. We should be concentrating on the OBG people regarding the video also, because Madam presented a very good video, and we will be getting regional videos in Malayalam also. I think that video, there is a small need of change in this thing. You should be consulting pediatric endocrinologists. That's not needed, I think, because in the coming months, that may not be possible, especially when you are targeting the rural and the interior. So that should be, that part can be avoided. The other things, it is an excellent video, especially the last part, including the normal baby at 15 years, that's a highly motivating part. But we should be preparing Malayalam videos also, and that Malayalam videos should not be targeted for the newborn baby OP. It should be basically for the OBG people. So I request IAP to be including the OBG people. At least 2 meetings should be a combined meeting in the coming year.
Yes, sir.
And apart from this thyroid program, there are many programs in the Presidential Action Plan where it can be successful only the OBG people are involved. So please see that at least 1 or 2 meetings are conducted with the combined manner with the OBG people. Then one more thing about the awareness part, Menons are stressed, and many of you stressed without the general population knowing, this won't be a success. So 2 people need to be considered. That is the general population and the lowermost part of the health workers. So when you are preparing module, whoever is preparing module, then a little small part of Malayalam regional language modules need to be prepared. That is basically meant for the lowermost health workers and the general public. And when you are preparing for the general public, of course, you have highlighted radio. That is something which is very easily they will be accepted. But the accepted means they'll be happy only to for the dissemination to the general public. Unlike the visual media, they'll be demanding. Visual media, it's not that much friendly for any of these things. They have got other interests. But the radio is very good. It's a good, better medium that will be reaching to the general population. So at the time when we are preparing the regional module for the general public, maybe for the print media and notice like situations and the small module printed, at the same time for the FM also, so that we can target the lower level health workers and the general public. This is more important not in the initial part of the diagnosis. This is more important for the follow-up and missing the dosages. Then one important thing, whether can we make this mandatory to ensure the newborn screening. The newborns are all registered, birth registries there. Can we include, when we ask government officials to include one column in the birth registry, whether this newborn screening is done? Maybe that is done after some days only. You will getting the newborn result after a few days only. But whether something is done, he'll precause and something is done, can it be involved in the birth registry so that there is some mandatory part is done? And this birth registry thing will be taken at the end of and many points later also, so that we can ensure that newborn screening was done. So that is making it a little mandatory. Then one point about the, you said 5 lakh kids only screening done from 2013. Every year 5 lakhs newborn babies are born. Now it's 9 years from 2013, almost 8.5, 9 years. So by that time, 13 lakh only done. Government machinery caters around 30% of the deliveries. So around 13 lakhs of babies were born during this period, only 5 lakhs done. So our screening is only 35 to 40%.
That is initially, sir, from 2013 and initially from Calicut and Trivandrum they have started. Then other medical college it extended. That is why it took some time to extend to the district hospital like that.
So what I would like to know is, we need to have a data of all these 9 years from 2013. What was the pattern of the newborn registry, newborn screening? And for the last 2-3 years, government hospital delivery has increased from the 30% to higher level. So that also need to be considered, whether it's a proportionate increase in the newborn registry. At the same time, one more data we need to ensure is the regional public health lab from where you are getting this newborn thing. Many of these things are not very late. So at least we should collect the data, how late last few years we were receiving the result, so that we can convince the higher authorities that government machinery always there is a lagging in this thing. That is, unless we have data, we cannot convince the authorities. Then about the inclusion of the private institutions in this program, even though it looks good, 70% of the deliveries are happening in private institutions, why not? But that's not going to improve the overall number. Maybe because they are all even otherwise doing that. So for a program success, as Madam already highlighted, we should be concentrating more and more on the marginalized and the interior thing. So making this corporate sector or private institutions free of charge doesn't make much of a difference for our program success. So that part we should be catering more on the dissemination of this information and see the screening is happening at the lower level, and especially the marginalized population, tribals and the other people. So how to involve them. Then another thing, I said OBG people should be taken into support. Again, our own IMA and the general, they say not on the pediatricians, general practitioners. One more thing, we need to include the next generation of doctors, younger MBBS students. So why not on May 25th, Can we conduct a medal examination or something so that they'll prepare something? And unless these things are there in the assessment, they won't be reading. So few questions also we ask the teachers in the medical profession to include a bit more of endocrinology topic, and that will ensure that they'll read about it. The use of the media and many of the other things I have written is covered. One thing is Menon sir already highlighted in the coming months liquid preparations should be available, but maybe it won't come soon. So about the crushing of the tablets and breaking the tablets, can we avoid that, especially for the preterm and very low birth weight we are starting? Because it's almost 7 days of the half-life is there. Is it possible for giving the whole tablet only 25 microgram on 72 hours or when you alternate day or weekly twice? There's a problem. If you are not giving daily, this can be forgetting this thing is there, of course. But avoiding the breaking the tablets, can it be done? That's it. Thank you.
Thank you, sir. Actually, we are planning. Thank you, sir, all the suggestions. We are planning. Actually, I had left it out. One of the plans for also for ICD through the ICDs for classes for Anganwadi workers also in Malayalam. That's again that module will be preparing, sir.
That is our plan actually, sir. Then 12.5 microgram tablet is also there now.
Oh, then it's a comparatively. Okay.
Sir, Menon sir.
5 milligram tablet is not always available. It's not available every place at all given time. That is one. Even thyroxine tablet, 25 microgram is sometimes not available. They are very small tablets. So the general rule is that, of course, in medical colleges with a very good pharmacology department, you can actually crush the tablet, measure it, and then make a powder, what we call in Delhi pudia. And then mothers are given actually measured tablets. So that requires a good pharmacology or pharmacy department to do. The thumb rule is that if you have to break a tablet, use the tablet, you look at it whether it is exactly half or broken into 3 pieces. Whatever pieces you give, the rest is given on the next day. So that the dose is not that you crush or make a new tablet to make it exactly half. That is one. Second is that if there is a problem, many people are seen looking at whether it can be dissolved in water and then measuring, you dissolve it in 1 ml or 2 ml and then crush it and then give. That doesn't work. The bioavailability decreases. So the best is actually in our situation to give a broken tablet every day. One of the reasons why I insist on daily is that it becomes a habit. The mother also and the child also knows that they have a tablet. You miss 1 day, the chances are that you will miss more than 1 day. And then there is always guilt comes in. You start making up. So when you want to see deeper, they take 2 tablets on the previous day, and then you have complications with interpretation of the labs. So the avoidance is that if you forgot, be honest and say, we forgot the tablet. And that would be the best way to be, number one. Number two, the problem is that I don't want to discourage private entrepreneurship in newborn screening program. Everybody should be together. How much is the utility in starting a particular program in private sector? We have to see what happened to COVID vaccination. Sometimes it is not possible for the government institution to take up the load of the children landing up for newborn screening on a fixed time at a particular time with the shortage of doctors, strike of doctors. There is buns and everything. People find it difficult to come to hospital. So if you make a center available for testing without charges, whether it is a private center, whether it is at a government center, whether it is a NGO organization, it doesn't matter. The only thing is the person who takes the sample of blood should be experienced to make a correct sampling of the filter paper at the correct time, making it that the well is completely filled, it is not overfilled, it is not spilled, and it is not painful for the child as well as the mother to do that. So the private entrepreneurship is is to encourage more people to get tests done at nearby places. So that is one. Of course, if you have to reach, you have to go through our ASHA workers. I think they are the right people if you have to get it into remote areas. And you have to ensure that the primary health center, whichever is the center, they are the staff. And I must say that worldwide the experience is that it is the nursing professionals who are better in doing this stuff than medical students and medical doctors. Unfortunately, they think they have more important in emergency work and everything. They do not allocate time for these type of what we call as routine or mundane work, which is much more important. We are all busy with saving lives. So pricking a heel prick is a secondary predisposition. You are very right, Dr. Bushman, about collaboration. Nothing will succeed in any neonatal screening program, whether it is hypothyroidism, whether it is any other thing, without the help of the obstetricians. It is very important that we are also part of it. So it is very correct. One correction about the video. The video is actually, it is in Tamil. I have seen it and edited, and also the Telugu version of that. The person who is seeing the newborn baby or the young baby is a pediatrician. He is telling that if you want, you can also go to a pediatric endocrinologist to confirm. This we do. For example, suppose what do you do when you see a child with seizures in the first week or a child with developmental delay? There you are not sure. The pediatrician is not sure to say that everything is all right, or you are not able to pinpoint, you don't have the center to do the specific testing. You would definitely say you go to a developmental pediatrician or a neurologist. How many developmental pediatricians are there in this country, in the state of Kerala? It's a pediatrics depends on growth and development, but developmental pediatrics is something which has been probably ignored by pediatricians. We do not have developmental pediatrics as a specialty subject, except by a few centers and the equipment needed. This is despite landmark work done by Professor M.K.C. Nair in the state of Kerala. So it is actually, we have to be careful. If a person wants a second opinion, there should be. So we now do not say that there is a pediatric endocrinologist. A pediatrician interested in thyroid diseases is good enough for a second opinion. Because when you say that you have to give a tablet continuously, daily, without forgetting for 3 years, do testing every 4 weeks, and then titrate, it is, many people will feel that my baby is looking normal, why should I be bothered about it? There are many people who miss tablets despite being given, and later to come and we find that their neural outcome is bad. So there is a lot of things which is very practical that you have suggested. I think Dr. Vijay Kumar not only heard but also made a point.
Yes, sir.
Noted everything, and I think these are all very valid and important points in actual implementation. All programs start with good ambitions, good aims, but die out because of poor functionality. So you have to keep people motivated. So when you say that ASHA worker has to do it, I think the poor girl is actually already overburdened with work. So you have to see how best it can be done by her without her other routine work being affected. One reason why we say heel prick is to be done is because we can fix a time of a day to collect samples. Cord blood means you have to wait for the baby to come. And who is there to be there at time to collect the sample or a filter paper? So practicality tells that it is much easier to collect samples on a given day. Everybody knows that at this particular time it will be done. This is valid not only for thyroid. If you are doing CDH screening for hip dysplasia and you are going to do an ultrasound, you are giving them time. aren't we? If you are going to do a hearing assessment for screening for hearing, are we not giving a time? So why should there be a disparity for blood testing? It should be done at a time convenient for the mothers, not the babies. Babies are at the will and discretion of the mothers. Should be favorable for. About the fasting, I think babies are continuously feeding. So there is nothing called fasting for taking the sample or for taking the medicine. We try to make it a routine. The main thing is that, well, if you give the tablet at noon time, will it produce hypothyroid child? If you forgot, then will you give it in the evening? There is nothing wrong. We would say that give the tablet as soon as you remember that I have not given it. But try to give it before feeds, because there are so many things in the milk the baby is essentially taking that can probably delay the absorption of the tablet. That is the reason why we say that early, because the mother makes it a routine like brushing teeth and keeping the baby. You know that it is being done. So similarly, testing. Does it really have to be immediately after testing? Preferably between 2 feeds, you can do the testing in a baby who is 1 month, 2 months, 3 months, even up to 6 months. That fasting to be done is actually an adult phenomenon. It is not for pediatrics or neonatal. And if you really want to know whether the tablet has been effective, it is better to do it after giving the tablet, but not later than 4 months. So it is again convenient timing. For a mother to wait with the baby at 8 o'clock in the morning in front of the lab, coming from a distance and waiting for somebody to prick the baby, it is not a good thing. Second is that it is not easy to bleed this baby, 2 ml of blood. So you have to be very, very careful what you are advising.
Can we not have dispersible tablet?
It is currently in India, we do not have any company. Eltroxin, Thyroxine, Thyronome, all are very cheap tablets. No company would go to the extent of making a dispersible tablet because our market is adult oriented. For every one child who is taking a thyroxine tablet, there are 100 to 150 adults, especially ladies, taking tablets of 100 milligrams. And most of the adults are on a dose between 100 to 150. So the market is low for the low tablets like 50, 25, and most of the people. I think in India at the moment, only 2 companies are consistently marketing low-dose thyroxine tablets at the moment. This story is no different for other world. Even in the developed world, lower dose tablets are not easy to get. It's not easy. Liquid preparations, for example, in a rich country where I'm currently working, because government procures for everybody, irrespective of the nationality. It is not available. The company do not produce, so it is not easy. So we all hoard on this medicine, keep it on store for those who cannot take a tablet for some reason. What do you do for a very low birth weight baby who is 800 grams and has come out of the NICU, has to be given thyroxine? Sometimes even you have to give 8 micrograms, even less than that to give. So such cases, definitely you need a liquid preparation which can be administered with a drop. But I think we should actually be looking at the overall general, which is much easier. If it comes to that of low doses, I would say that crush a 25 microgram tablets, give half on one day, give 25 on the next day if you have to give something between 17 to 20 microgram daily. So that, but do not keep hoarding the broken tablets to later. Don't crush the tablet every day. Give the remainder on the next day, add on to that and then keep it. That would be the easiest way. Most important thing is to have the time fixed for a day so that the baby system, the central nervous system and the endocrine system is used to the supply of the milk.
are we having lesser number of hypothyroidism after gynecologists have started antenatally thyroid tablets for mothers who have got less than 4 TS, more than 4 TS? It has got some effect, I think, definitely.
Yes, definitely. There are international guidelines which are practiced by the obstetricians and gynecologists, by international bodies on obstetricians. You have to realize that the diagnosis of hypothyroidism in a pregnant woman, the criteria are different from that from a normal adult. Values are much less than that. For example, it is around 2.5 to 3.5 in the first trimester and then further decreases. This is related to the blood volume and other changes that are happening during pregnancy. You have to realize that there is an added problem of that a mother with hypothyroidism may not be having just congenital hypothyroidism, but may have any cause of acquired hypothyroidism like an antibody-mediated hypothyroidism. And the antibodies also can transfer through the placenta and to the baby and can create a havoc. So a baby born to a mother with hypothyroidism, as well as a baby born to a mother with hyperthyroidism, are at higher risk for developing a thyroid-related disease in infancy than a normal population. Unfortunately, we always talk about infant of diabetic mothers. We never speak about infant of mothers with hypothyroidism or hyperthyroidism. We run around and look up when we suddenly find a problem. We start consulting books, Avery and Neonatology for far, and then try to find out how to do it. But there are international guidelines which are prescribed for the obstetricians and also specified for neonatologists also for such management. The criteria are not different. Irrespective of whether the mother has hypothyroidism or hyperthyroidism, the diagnostic criteria for neonatal congenital hypothyroidism remains the same. But relatively higher incidence is seen in these mothers. There are very few studies in India of a large number of hypothyroid mothers followed up and evaluated for development of congenital hypothyroidism in the newborn period. The largest study has only 200 mothers. Unfortunately, most of these studies have been done as an MD thesis of a gynecology or obstetrics department with hardly any involvement or a co-guide from pediatrics, or sometimes it may be an adult gyno. And the technology used in evaluation sometimes are probably not that great. And the student who does the thesis hardly touches the newborn or sees the newborn. Only the blood values are seen. So there is a lot of difficulties in interpreting the data which is available from Indian studies at the moment. There is a handful of studies on such things. Doesn't mean that there is no incident. The world over, it is felt that these mothers, the babies born to these mothers are at higher risk for developing thyroid-related disease, especially in the first week, and many of them may have actually a transient form of disease. If there are no questions, I think, Deepa, I must congratulate you for an excellent preparation. The guideline which Deepa has shown is actually available at the Indian Journal of Pediatric website. I think the Kerala team of IAP has done a good job in having discussion about this topic in various fora. Especially, I must thank Dr. Keshavan for including this in more than 2 CMEs in the last year. And maybe the influence of Dr. Vijay Kumar and Dr. Riaz, I think I must give them credit for being after this project. I think after diabetes mellitus, the largest chronic endocrine disease, it is now believed that after asthma, diabetes, probably thyroid is probably the number 4 chronic disease requiring ambulatory treatment in pediatric practice all over world over at the moment. So I think we have to probably stress a little more on thyroid diseases, especially in the children. Congratulations once again to the IAP team.
Thank you, sir.
Shall we conclude, sir?
If there are no questions,
Parvati madam.
Then,
Shaila madam.
congratulations to all of you for having this wonderful session. It's a very good module, and as Dr. Purushothaman has mentioned, we have to include the obstetricians on our side, just like in BFHI, MBFHI, Vijay Kumar. That is one thing.
Actually, we have discussed with perinatology chapter and the gynecology association also.
No, FOGSI is probably the right organization to be after. FOGSI.
Nice to see you. Bye. Bye.
Shaila madam is
So the obstetricians are always worried about the cost, sir. They say we do something else, bills will be high. No, it's very difficult to impress upon them or talk with them in a very, I don't know, with them.
I think one advantage of this particular program is that you are actually defraying the expenses involved by the parents in monitoring the child by the IAP, and the government is actually doing. It is free service for the baby. So that should not be the reason for missing out the program. If it is being charged, the newborn screening is charged, as I said, in a private center or in government service, it will beat the purpose of the national screen, neonatal screen. So if we are providing the service under the government's program and also popularized by the IAP, it should be acceptable to all practitioners. It is not one person's cup of tea. It should not be. There should not be any charge involved. Why has the Mithai program of Kerala government succeeded? Because you are giving insulin free of cost. You are giving glucometers free of cost. Even the higher brand of insulin, which are very costly, government is giving to few, at least some selected groups are getting. It should spread to far and wide. Similarly, newborn screening should be available. Let me tell you, hypothyroidism is only one of the screening that you are going to do. Once you start, automatically galactosemia, maple syrup disease, phenylketonuria, and a host of other metabolic diseases. I already have heard about Dr. Shankar, who is working in genetic department pediatrics at SAT hospital, making a plan for including this as a part of the thing. It would be wonderful if it happens. All screening, it will be, thyroid would be the basis on which all other can be pinged on, and then you can get the screening.
Shaila madam, any suggestions, madam?
No, I think a lot of suggestions have been made. I think we need to remember and implement them. It's a very, very good start. I think you will do well. Congratulations and all the best.
Thank you.
Thank you, madam.
On the behalf of organizing team, let me express my sincere gratitude to each and every person who has attended this and participated in this, starting from Menon sir for inaugurating this program, as well as for the more the guidance. We learn more and more things from you every day, sir. And Shaila madam, Vijay Kumar sir, and Dr. Deepa for the excellent presentation, and for all the and to all the seniors, including Purushottam sir, Parvati madam. So, shall we wind up, sir? Then, thank you so much.
Congratulations, Deepa, for that excellent talk.
Thank you.
Thank you. Thank you.
Thank you and bye. Good night.